My name is Dr. Tyler Tolbert.
And I'm Dr. Soren Paape,
And you're listening to the Fix Podcast.
your source for all things implant dentistry.
I've been so impressed with, I feel like we entered dentistry at the coolest time ever.
Yeah, for
right?
sure.
Just as computers are coming out and all this crazy technology and all the materials. And we're in America where people are spending billions of dollars on all the newest equipment, all these things. It's like we get to just put it in our patients' mouths and have the coolest technology and the coolest materials. And I'm like, man, when we've just graduated dental school, none of this crap existed.
Yeah.
And dentistry was not near as fun as it is now. And how cool is it that we are doing this right now at the coolest time of all of this stuff existing?
I love how you guys you mentioned that you guys were using a CEREC Blue Cam at one point.
Yeah.
And then you were trying to find the blocks for the CEREC milling machine, right? So
Try and angle the bridge just right so we could mill
get
that.
forward maybe and do it at an Emax. And obviously we're really grateful for innovation like zirconia in general and how prominent it's become within the dental world.
Yeah.
Because what we can do today is not something that could be done maybe 10 years ago, but definitely not 15 years ago. So yeah, to your point.
But even the zirconia 5 years ago didn't look good. Right. Zirconia 5 years ago, monolithic zirconia was not attractive. It was Bruxer, and it was only in the posterior. It wasn't in the anterior. Yeah. And so just over the course of the past 2 or 3 years, zirconia looks good and is super strong. Mm-hmm. And so just over the past few years, everything just seems like it is just moving forward so much quicker. And to be able to have the 3-on-6, I feel like it has kind of required having some really cool technologies to help make it more predictable and an easier procedure for the doctors to be able to do.
Yeah,
It's only going to get better too.
and one thing I didn't know is that you guys actually did a dentulous cases, right? And so Brandy actually showed a super atrophic case, one that would have been a pretty advanced FP3 case actually, and she was really wanting 3-on-6, and I was pretty surprised that you said yes to that. And your approach to it was phenomenal. We can probably talk about that case in particular in another segment, but how do you approach the edentulous cases? How do you recreate that architecture when everything is just flat?
Yeah, so a lot of people are saying it's flat, I should scallop, right?
Yeah.
The bone. And for the most part, when it's flat, they've already lost a lot of bone. So it's we're not needing to scallop the bone, we're needing to build up the bone and build up some scalloping, build up more tissue. So in a case like hers, in these edentulous cases, you can see that we're trying to put a ton of bone grafting in there, and we're taking a lot of tissue from the palate and moving it to the facial so that we can get a lot more tissue thickness on the facial and a lot more bone thickness up there. And really, we're just allowing the shape of the prosthetic to shape the tissue. We're suturing the tissue to the prosthetic, and we're having the ovate pontics in there and the shape going down to the implants. We have those shaped in a way that it helps create a tissue thickness around those implants, and in that way that will help make a beautiful tissue. And then one of the things that I showed you afterwards, oftentimes it doesn't all grow exactly perfect in those first 3 months, and so we'll have to go back, and then we will also compress that tissue a little bit more to try and shape it a little bit better. So there's the 2 different phases. One, we're trying to build up as much as we can, and we're going to lose a little bit of that, and then after that, shaping it a little bit more with our next prosthetic before we do the finals. So we've got 2 sets of prosthetic teeth, temporary teeth, before we do the final teeth. Okay. And so each one of those, we're shaping the tissue a little bit more and more before we get to the final teeth.
Yeah, I think.
In secondary intention, like you're saying.
Secondary intention, growing the tissue by secondary intention.
Yeah, and I thought it was really cool when you used the gum glue for secondary intention. You just kind of glue it to the
gold nugget for me, for sure.
Yeah, for sure. So I think one other thing that I noticed was there's a lot of patients that come in and they have a lot of implants, right? Trying to address 1 tooth at a time dentistry, trying to, also do all on 4, but not really having a great result, or seeing what your fans talk about and then wanting to just, feel like they have a part of them back that maybe got removed from them. How do you guys assess current implants when they come in and how to redo those? Are you guys always looking to start from scratch? Are you looking to incorporate previous implants? What's the dynamic and the balance there when you look at a patient like that?
Yeah, I always tell patients that I won't start out with a compromised implant. They're paying all this money. I want them to start out fresh. Now, if an implant is integrated and it's in a good spot, then I'm going to try and use it every single time. I feel that it's good for the patient to not go through the trauma of removing an implant if we don't have to. Also, I love having an integrated implant into my initial prosthetic. I think it helps with stability. I'm not as concerned with where I'm getting stability in my other implants. So it can be very helpful. We also look at what parts are compatible. Do we have stuff in our office that we can use? Because oftentimes we don't meet the patients until the week of. And so if we don't have a part for it, then maybe we're taking it out or we're burying it if we can work around it. But part of what we believe FP1 is such a atraumatic full mouth principle. It's a way to get a patient in start to finish without a ton of swelling, a ton of bruising, without a lot of trauma to their mouth. I mean, it's still a full mouth surgery, so there's still that, but
And I'd also
we can do the better.
And I'd also take into account the patient's age and health. If a patient, like a couple weeks ago, I had a patient that was older and in poor health, and I was planning on removing the implant, but I also didn't want him to be under anesthesia for longer than he needed to, so I changed the game plan, and I said, we're going to keep some of the implants that were healthy and strong, they just weren't ideal. And so instead of removing those, I just kept them in there and used them just because I didn't want him to be under anesthesia any longer than he needed to be.
But it is nice. It allows us kind of a freedom in treatment planning because we see a lot of people that have lost their posterior teeth. They have maybe really good lower anteriors. We see that's a pretty frequent thing for us is 22 to 27 are in good shape. Behind, we're in pretty bad shape. And so we will often treat patients in a way where they come in, they want a 3-on-6, but we want them to preserve their teeth if they can. So we'll do 2 posterior bridges, and I tell them all the time, look, we're just gonna do 2/3 of your 3-on-6, and if later on we need the last third, great, we'll do it. And it makes them feel like we're not pushing them into some sort of treatment that maybe they don't have to go through.
Do you provisionalize that immediately, or are you waiting 3 months to go back in and then shape tissue and whatnot? Because we didn't see that specific example, even though we saw the results of it.
I think we've done both ways. I think Dr. Roberts, you probably provisionalize more immediately than I do. I tend to wait a little bit longer.
Yeah, and for me, it kind of depends as well. Some patients, they'll want me to do anterior crowns on those ones, and so if I'm doing crowns, then I will load those, and I'll screw the teeth on and put the crowns on in one big piece. So then it's all together. If it's only the bridges and we're not doing anything else on the front ones, then I will just usually put it in the patient's hands and be like, there's a slightly higher chance of these failing if we load them right now. And they're usually like, oh, I'd rather just go without them. And I say, okay.
Yeah, I do see that in my office, loading those. If it's not cross-arch stability, loading them, I do get more failures. And I tell my patients pretty clearly that that's the case. And sometimes they want to run with it. Other times they're a little more cautious. Me personally, I probably would opt for being cautious if it was my mouth. But ultimately, and I tell my patients this too, my job is to give you the options and tell you the pros and cons of those options. I don't love when providers tell patients, hey, I'm only doing it this way or else. I think it's much better for giving the patient the opportunity to decide. And it also takes away a little bit of responsibility, which I think is fair, right, from the provider if the patient chooses to go down that route. Because ultimately, we can do whatever we want, but if the patient was the one that kind of pushed in that direction, totally appropriate, but then the patient knows and they understand that, hey, we need to remove this implant, now graft, and come back and place it later to get an optimal result, for sure.
Yeah, if we were perfect and we never messed up, then maybe we could say, no, this is what you should do.
Yes.
Right? But I feel like there's been a lot of times where I've recommended something, like there's been some cases where patients were like, I want to get all my teeth out and I want to get the 3-on-6, and I'm like, no, we're going to save the teeth that we can and we're going to do implants. And then within a couple years, all the rest of their teeth fell out. I'm like, crap, I should have just listened to the patient. And so I don't know everything. I'm not, I'm not God. And so I'm always going to give my patients my advice from my experience, but I also trust them because they potentially know their body and they know what's going on in their body better than I do. and they've got a lot of experience with their mouth, and they've got a lot of experience with their own teeth, and they can see the direction that it's going. And so I'm going to take into consideration what they're saying as well, and ultimately the decision will be theirs.
Yeah, for sure. I mean,
Easier to accept something that you chose.
Right.
yeah. And ultimately, like, I have patients that ask me all the time, like, how long are these implants gonna last? And it's like, man, if I could dictate like how the body's gonna heal, I'd be much richer, and that would be very nice. And every dentist would be doing this, right? If you could do that, but unfortunately, we can't. So it's just important to weigh the options, tell the patient those options, so that way when they decide, they can decide appropriately.
A lot of times patients think that like what we do is like carpentry or like construction, right? Like let's just stick a screw in a 2x4 or something like that, and that's what it's like. But what they forget and what we have to explain sometimes is like the bone is a living organ, and it remodels and it moves and it responds to things with stimuli. And we don't get to choose all the time how their body's going to respond to things. And there are really, really high success rates with implants. They've been known to work really well. I'd say that they're probably one of the number one medical innovations of the 20th century for sure, right? But there are things, especially when patients have deleterious habits, what they do at home, how they take care of it at home.
night.
We can't control that at all.
Yeah.
And I love, you said this, Randy, you said that to somebody, like I can do my best work, and if you don't treat it right, I can't control that. And my best work won't withstand the habits that you have at home. Right. So
I'm dealing with a sinus complication right now where we had oral antral communication and fixed it up the best I could. I did pulled the tissue down, did a pedicle graft, did some membranes. And I told the patient, hey, I did my job correctly. Now I need you to do your job. And that means going home, don't put pressure on your sinuses, don't smoke, don't do this, don't do that.
Don't sneeze.
Yeah. And she chose to keep smoking a pack a day afterwards, and it just isn't healing. And I'm like, hey, there's going to come a point where I'm doing everything I can on my end to help you out, but if you don't help yourself, then we're in a situation that's going to get worse and worse.
And that's expensive stuff, all those membranes and stuff. And so
It is, and a lot of times I do these like after a surgery as a courtesy to the patient for free, but I let her know like, hey, I'm doing my job, and I'm, taking my responsibility and putting my money into this. Once this goes too far and you're not listening to me, eventually we're gonna have to start charging you for these things.
Right.
And sometimes patients just don't understand that's where you get kind of like the butting heads.
you're not picking up a hamburger at McDonald's.
Yes.
You're actually participating in the surgery. You're half of the battle.
Correct.
So if you keep doing the same exact things that you did that led you to this point in your life, there's a good chance that these same outcomes are going to happen with the new set of teeth or the new implant.
Maybe even higher chance because these weren't made by God.
Your man alone. That is good.
But this is why, FP1 is important, right? Is because ultimately what we're doing is hopefully providing another set of teeth. Like I tell my patients, you're born with a set of baby teeth, then you get a permanent teeth, and then these fixed teeth are kind of your third option, right? Once you get past that, it gets really hard. But if you can squeeze one more lifelong set of teeth in there, ideally it'd be great if they lasted forever, right? But ultimately, that's probably, there's going to be something that occurs, especially if they're getting it done in their 30s or 40s over their lifetime, and then we still have another option past that.
that's why it's funny when the patients are coming in right now saying well, in Japan they're using stem cells to regrow teeth, and it's like, well, your teeth are still going to end up in the same place, even if they're second or fourth.
Yes.
So anyway,
Yeah, that whole stuff is funny. We'll see what happens with that.
that's awesome.
Put a stem cell and the tooth grows like this.
It'd be great if it could happen. We'd all be stoked about that. I mean, our ultimate goal is that patients are happy and whole. That's what we want, and anything that helps get them to that end goal, that's what we want. And if that's great treatment from other providers, we want that too. And I love that about 3 on 6 too, is you're empowering other dentists to do really good dentistry. It's not about you. It's not about your teachings necessarily. It's not about what does this bring to me as a mentor. It's about, hey, let's take care of people. There's 12 million people in America that don't have any teeth. Let's take care of them. And let's do it. And we need other dentists. We need them to be doing their best work in order to get there. So, yeah.
Another thing that reminded me, we were talking about those posterior ridges and whether to load, whether not to. So one thing that FE3 is foundational with is cross-arch stability, right? We put in all these implants, we're looking for cross-arch stability. That's how we're able to make immediate load work. And I understand, of course, now that, when you guys are temporizing your cases, that is a full arch, splinted thing. So same principle.
We agree, yeah.
However, once everything has been integrated and we've gotten through that initial remodeling phase and now things are there, now we're segmenting. Can you guys speak to why that matters and why that may be beneficial as opposed to doing full arch splinted FP1, which other providers are doing as well?
Yeah. So there's a couple principles that we follow. We want as sleek and as small of a prosthetic as possible. And so we're dealing with a restorative space of sometimes 6 to 8 millimeters. And so the longer the span, the more likely that is to fracture. And I think that, that's initially what drove it was these are going to break with time if we keep doing them fully splinted. And so then Randy's looking at these cases and he's saying, well, we do implant bridges all the time. It's just one segment. We do an anterior implant bridge. Let's just keep doing that across the arch. And then we started looking into it more, and we found that we were getting greater bone density around the implants after we splinted them. They started to look better in our CVCTs, that the bone wasn't resorbing over time. And we look into progressive loading and what that means in dentistry. And that's really what drove us to continue with, because materials are going to get better. And who's to say that, after zirconia, maybe there's something even better that's even stronger at 6 to 8 millimeters. But I still think it's going to be necessary, even if the materials get better, to segment the arch so that we can get the proper pressure on the implants to stimulate the bone. And I think that's where we're seeing incredible results with greater bone-to-implant contact over time. And we hope to be able to, with time, show that even greater in studies and things that we're trying to put together. But for now, we see it in our patients, and the progressive loading, I think, is a big factor in the health of the implants.
Yeah, Wolff's law states that the more pressure you put on your bone, the stronger the density will be. So if you're working out your muscles will get bigger, but your bones are also going to get stronger because there's more stress on them. And so we are finding that when we break up the bridges, the restoration into bridges, there's more stress on each one of those implants, which puts more stress on that bone, which means that bone is going to be stronger. There's going to be more calcium deposits, going to be a more dense bone all the way around that implant, just because it's a law of nature. It either is going to have to die or it's going to have to get stronger. And so we're finding that as we slowly put more load on that, the bone has to get stronger to be able to compensate for that stronger load. And putting it into a full arch that's fixed makes it so that it's safer for the beginning because there's less load on each of those implants. But over time, you want to increase that load so that the bone can continue increasing in density.
Yeah, we do believe, there is a traumatic load, right? There is a point to where that load is too much. But as long as we're managing the occlusion, we're managing clenching and grinding at nighttime, that load should be within the realm where it is creating bone and not removing it.
Right. So by taking away that forced dissipation of cross-arch stability, you're able to load more bone as long as the body's ability to grow bone is outpacing the osteoclastic activity, then you're going to get a positive result over time.
Yeah.
Right. And combining that with our AlgaeCal, with our vitamin D, we feel like we're seeing that patients are able to create more dense bone around.
Why don't you talk a little bit about that?
Yeah.
The AlgaeCal and what your experience is with it.
Okay, so at first we were trying to patients with different types of calcium, and we have found through different studies now that the people that are just taking calcium, their most calcium over the counter comes from coral, and it's calcium carbonate. And we have found that that's more difficult for your body to assimilate into the bones, and it's actually causing people to have like kidney stones because it's just gathering in your right. So, but with the algae calcium, we're finding that it's actually depositing into your bone, and so we're making all of our patients start taking it as soon as they're scheduling for their appointments, and definitely at least do the first 3 months during surgery. But then one of our requirements to maintain their warranty for their teeth is to continue taking the algae calcium for the rest of their life, because that way we know that they're getting a good source of calcium, they're getting a good source of vitamin D, and that their bone density will continue to increase throughout their life instead of going away. Because we have patients in their 80s and 90s that have really strong bone as long as they're getting a good source of calcium. We have patients in their 40s that have no bone because they're not. And so especially with patients who are lactose intolerant, which is a much higher rate of people these days, they need a good source of calcium. And this is just one that we have found to be a really good source of calcium that easily deposits into their bones.
What's kind of your protocol for that? So let's say a patient comes in, right, on a Tuesday, and they're like, oh, yep, I want to get this done. I want to get it done right away. Are you comfortable doing that surgery and having them maybe start the AlgaeCal like a couple days before? I mean, in an ideal world, I'm sure they've been taking AlgaeCal for months, right? But like, what's kind of like your minimum, or what do you kind of try to shoot for?
We don't have like a minimum, because sometimes we do have like an opening in 2 days, and we'll get them on it starting then.
Right.
But ideally, as soon as they schedule, we're trying to get them on them as soon as we can. So if people that are scheduling from out of state, we're sending them their package, and they're sending them their first bottle of AlgaeCal for free, because we want them to be on there. And then for all of it after that, then we sell them the AlgaeCal, and I think it's like $35 a bottle. If you go to AlgaeCal.com, it's like $80, $90 a bottle. It used to be like $100 a bottle, which is why we started making our own, so that we could sell it for, half the price of, or a third of the price of what they were selling it for.
Yeah.
One thing that I really love about your guys' business, right? Not just like the dentistry and the stuff that you're doing, is you do have value adds, right? And that's actually why we're here also, as part of that. The AlgaeCal, like, you're creating a situation in which there's a value add of something that's going to stick with the people or the patients for the rest of their life, right?
Mm-hmm.
You're gonna buy every single month a $35 bottle of calcium
Yeah.
to help ensure that all the work that we did lasts as long as possible. So that's great business sense. The other thing I really love was the 4-on-8. So like, not everyone has heard about 4-on-8, but you have a lot of branding around 3-on-6, like even just the name of 3-on-6, right? That's a branded version of an FP1 that you guys have control over. And we're here to participate in the success of what you have going there. But the 4-on-6 is even like a more executive decision for people, or an upsell. I don't want to say upsell, but it's an upsell,
Yeah.
right? Can you kind of talk about like what you've seen as far as people coming in? We've already talked about like the penny pinchers, but like people coming in and wanting to spend more money and just wanting to have the best possible option in their mouth, and what that's done for your business.
Yeah, we have found that certain implant placement allows us to do different things. So when we create a midline split, so one of our bridges section right at the center, it creates a really natural looking outcome versus having 7 through 10 as one bridge. And so we look at playing with where the implant placement needs to go in order to still segment into 3 separate bridges. Well, in order to do that, we're better off with 4 bridges. We ended up with patients that were already in second molar occlusion, and to take them into a first molar, they weren't as thrilled with that. Yeah. So we started placing implants a little further back and creating 4 bridges on these 8 implants. And it was, it's a little extra work. It's extra planning. The surgery is a little bit harder because we end up losing guide teeth for the guys. So we price it accordingly. And for a lot of patients that are looking for the best of the best, and they're looking to get all of their teeth back so that they feel like they have as much surface area to chew with as possible, that's been a really good kind of an upsell. It's something that they can do if they want to. I try not to push patients either way. And so when I walk out of a room, I tell our sales guy, look, they're a great candidate for 3-on-6. They're a great candidate for 4-on-8. Whichever one they decide, I'm fine with. And we leave it up to the patient. And if they want that, then that's generally something that we can do for them. And it adds value to us because it does a little more work. But the surgery obviously pays a little bit more as well.
Yeah. And one of the biggest selling points for me to my patients is that with the 3-on-6, one of the biggest complications that we have over time is that some of the bridges can come loose. And so maybe after 2 or 3 years, one of the bridges will have to come back, and once to tighten it down, it takes a little bit, which isn't that big of a deal for somebody that's close, but for somebody that's far away, that's a bigger deal to have to fly in here to just tighten down a bridge, or to go find a new dentist that can tighten it down for them. Whereas with the 4-on-8, we haven't had any of those come loose still. So it's just it's one of those things where just having a couple more implants in there, it seems like it's making a big enough difference to not have fewer complications in the long run. So that's a big selling point. I feel like that makes it so that it's maybe worth paying a little bit extra to have your full mouth of teeth, to have a little bit more stability, have a little bit less likelihood of having a complication in the future.
Something that I'm impressed with too is I have seen some FP1 cases incorporate pterygoids. I have one personally. But where I've seen it at other FP1 courses and things is almost invariably the restoration is a full arch splinter restoration with a titanium substructure, right? Because that's the only way they can handle that kind of span when they're dealing with last restorative space, kind of like what you were saying earlier, Dr. Luck. And the additional benefit of ending up in these splinted monolithic zirconia restorations is you have an ultra polished intaglio and you're getting that epithelial attachment. So when we've seen you guys take some of these bridges off and there's no screw in the restoration, there's absolutely nothing mechanical retaining it, but biomechanically there is clearly attachment. You're having to pull this thing off and it's bleeding when you take it off. And that's a bacterial seal. And that is a huge advantage that helps protect this work long term. And I've been super impressed and challenged mentally on how I can start doing more of this segmentation, getting that ultra polished zirconia to get that type of attachment, because I'm not used to seeing that.
Yeah.
So that was really impressive. And another thing about this modality that I think is going to help it stand the test of time.
You know, in the next probably 5 years, my assumption is a lot more AI in design. It's going to be easier and easier for the provider to actually do the design, because even already, like if you go on exocad, there's a lot of tools that utilize AI to make, you know, the experience a lot simpler. Between that and printing materials getting stronger and stronger, my assumption is that, you know, in the next 5 years, we will probably have a real option as a printed final. Right now, there's materials that claim that it can be a final, but we've seen that, you know, it's not super realistic, and maybe not, it doesn't stand a test of time with like staining and stuff like that zirconia does. But I do think that it is gonna come sooner rather than later, and we're gonna be in a situation where we can really provide a final solution for these in a day.
Yeah.
And I think that is gonna get even cooler when stuff like that can happen.
Totally.
Well, guys, I mean, I think that I speak for all of us when I say that, you know, we have just learned so much and coming here, and we've been humbled in many ways. And I hope that we maybe offer some things that maybe you guys can learn from as well. Yeah. You know, and we're just so excited to go into our surgeries tomorrow and, you know, really get in the trenches with this technique and do atraumatic extractions. Didn't even really know what that was when we came in. I've definitely never sectioned a canine in 4 places. Logan taught us how to do that. So we'll see how that plays out. We'll definitely do a recap and kind of talk about, you know, what that really consisted of and what our experience was as surgeons doing this for the first time. But I just really want to thank you guys for putting this on, being so welcoming, you know, bringing the FP3 versus the FP1 and taking out the versus part of maybe making a slash, you know, allowing us to come together and, you know, have a congress and just talk about how, you know, we can just do better for these patients. And that's really what it's all about. So really appreciate you guys.
Yeah, we're really humbled and grateful to have you guys as part of the group. You know, as we go through this, we get more and more talented doctors that add to the family that we have, and we can learn a ton from you guys' experience and from your business acumen and for what you guys are doing. We love having talented doctors in our family, and we're excited to have you guys there.
Yeah, thank you guys so much for being here and for coming and taking our course and making us feel like we're cool. We appreciate it.
Well, appreciate that. I will say that it's so important for doctors to not like just be all FP3 or all FP1. You know, it's really, really important for all providers to see the pros and cons of how different doctors work, and that's ultimately how you become a more skilled clinician, is by being able to offer more of these treatments to their patients. And I think that that's where I just see a lot of doctors that are very stuck in their way, that it's their way or the highway, and it doesn't serve their patients long term. So I'm glad that we could kind of come together with our FP3 and your FP1, and hopefully, you know, you guys can learn from us as far as maybe a little more remote anchorage, pterygoid, stuff like that goes. Yeah. And we can learn from you guys to provide another option for our patients who might not need to remove quite as much bone. So I really appreciate it, and thanks so much for letting us be here.
Yeah, thank you.
Maybe this won't be the only Fix on 6 segment. Who knows?
Yeah. So hopefully there's more.
Stay tuned.
All right. And thanks for coming to the 3 on 6 podcast.
Thanks so much.
And we'll see you guys next time.
If you're considering restorative dentistry with dental implants, you should know all of your options. Head to 3on6.com and book a free consultation with a 3 on 6 provider near you. If you enjoyed this content, please like, subscribe, share, or leave a review in the comments. Until next time, keep smiling.